समझ नहीं आ रहा अपने सैलरी इंक्रीमेंट का क्या करूं।
बेटा इतना क्या सोच रहा है, अपने म्यूचुअल फंड्स के एसआईपी का टॉप अप करा ले। दिस इज द राइट टाइम।
क्या समझ में नहीं आया?
बेटा इतना क्या सोच रहा है? अपने म्यूचुअल फंड्स का एसआईपी टॉप अप करा ले। दिस इज द राइट टाइम।
आप समझा।
Mutual fund investments are subject to market risks. Read all scheme-related documents carefully.
So, over what period of time would somebody who's taking a GLP drug begin to see changes in weight loss?
It's hugely variable, Barkha. So, typically we tell a patient to be patient for 3 months. Okay? But there are some who lose weight in the first month. 3, 4, 5 kilograms. There are some who start losing weight after 3 months. So there is a lot of variation. But you would say that by 3 months, if you are not seeing a result, something's not okay. We need
And
to
what
look.
would that be? It doesn't work on everyone? What's your experience?
So it doesn't work on everyone. Roughly 10% of people don't respond well, which means they respond with a weight loss of 3 kilograms or something, which is called a poor responder. The newer developments in this will keep reducing this proportion to less than maybe 10 to 5 to 3 to 2, but there's never any drug that works for everyone. So there will be 10% people who we discussed this point at the beginning itself, because setting expectation is very important. So there will be 10% people who don't respond that well as we would like them to, so we classify them as non-responders.
What is the difference between all the drugs available in this category? How do they act differently? What is their difference? Is it a difference only of brand name, or are there fundamental differences between, let's say, an Ozempic and a mounjaro?
Yes. So just to sort of preface that, GLP-1 drugs we have been using for treating diabetes since 2005.
So these drugs have existed since 2005?
Not these two, but their predecessors.
Okay.
So we have a whole cupboard of GLP-1 drugs.
Okay.
First one was something called exenatide, then liraglutide, dulaglutide, all those with them. They were all very good anti-diabetes agents. They didn't become so popular because they're injectable. Now,
But ये भी तो injectables है.
I know, but the thing is that for weight, people do much more than they do for diabetes.
Imagine the irony.
But that's what it is.
Yeah.
So the key thing that these two molecules have done, the ones you're talking about, is they've crossed that 15-20% threshold. I mean, that is huge.
Explain that.
Which means that if someone is 100 kilograms, one can, and doesn't have any other sort of, there are a lot of subtleties and nuances there, but it's straight weight reduction. Then you actually can expect to lose 15 to 20 kilograms.
In what time period?
Maybe 6 months.
Wow.
Yeah. Maybe a year, but definitely by a year. I mean, most people would do that.
And those who don't respond, do we know why they don't respond before we come to the success stories?
That's the research. That's the current research. Who are the non-responders? And we are facing that too. We are analyzing our own data and worldwide people, because once a drug is successful, that becomes the next point. Who are the guys who are not responding? So one group, for example, is very important to understand that people with diabetes respond little less than those without diabetes. So those with diabetes, they lose 20 kilograms, let's say. Then a person with diabetes maybe will lose 15.
Now, these drugs, as you said, were created as diabetes drugs.
Yes.
And the weight loss dimension of them was discovered, I guess, quite by accident, or as a positive side effect or so on. However, now they're primarily weight loss drugs and not drugs to treat diabetes. I think the way to think of it, though, is that this is not a cosmetic intervention, but a health intervention, because so many other diseases are related to being obese. Arthritis, I don't know, autoimmune diseases, and so on. So how do we understand these drugs? One way of understanding them is these are, earlier when they first came, they were considered the drugs of the elite, the super rich. Now they're not now they're not seen as that, right? How do you look at these drugs? Do you look at them as a way for people who want to look better? Or do you actually look at them as this is a really serious, dramatic health intervention?
So I think the latter is definitely true. I think these drugs are game changers for our health. They are not for everybody and they may have side effects. We'll talk about that.
Yeah.
But the truth is that doctors are not looking at these drugs as cosmetic measures. We are looking clearly at obesity is a condition or a disease. If we lose fat, along with other beneficial effects, we'll get, diabetes will go away.
Yeah.
Blood pressure will come down.
Yeah.
Heart disease will come down. Kidney disease progression comes down. Fatty liver melts away. And then the arthritis and all those other things. So it's a huge medical advance, which is what I keep telling people. When you're looking at them purely as cosmetic drugs and then you're looking at side effects, a different story. We are looking at these drugs reducing, semaglutide for example, 20% reduction in cardiac events for people with diabetes.
Can you take us through in detail how this drug acts?
So,
any of these drugs, there's not one.
Semaglutide is the prototype right now. That is a GLP-1 agonist. That is a drug that acts like GLP-1, acts on the pancreas to enhance secretion of insulin, suppresses the glucagon, acts on the brain to control our appetite and other things, acts on the movement of the gut. It slows down stomach movement. So all these things this drug does. Now, there are many other modes of action which are not understood.
Like
anti-inflammatory action, it seems, is more than just through the fat.
So you mean it's an you mean that apart from containing weight or reducing weight, it is having an anti-inflammatory impact.
What recent studies
that could help other diseases triggered by inflammation.
Yes. That's exactly what current.
Like Alzheimer's?
So Alzheimer's much of these effects are linked to just fat. See,
Alzheimer's is linked to fat?
We look at like weight, external weight. But what happens is there's fat deposited inside our organs, around our organs. And that plays a big role. Like the liver, you all know fatty liver. That is fat inside the liver. So similarly, there are brain lipid alterations. Now, these drugs presumably act at that level. And therefore, Alzheimer's studies are fascinating. Even Parkinson's, not proven yet, both of these. But Alzheimer's is at a more advanced stage. And we do expect that something positive will come out, but we have to wait and see. So the action, and we'll find many other benefits, that's my guess. The key research questions, one you already asked, who are the responders, who are the non-responders? The second is, what actions are determined purely by reduction of adipose tissue, as we call fat inside, and what are independent of that? That is being worked out. And one of the things that's emerging in that is that the anti-inflammatory action may be not just linked to the reduction in fat.
And that's fascinating and fabulous. But let's come to the flip side, the side effects, right? One of the things that sounds scary, somebody like me who has a nervous stomach, travels a lot, is on the road a lot, has to work a lot, gets uncomfortable if my stomach is not feeling comfortable. Here's these stories of periods of nausea, gastric discomfort. How severe are these? Do we have enough research? Are they mild? Are they the kind that, you have a loose tummy, you take a Norflox, it becomes okay. You take a Perinom for your nausea, it becomes okay. Or is it something graver?
With full doses of these drugs, almost half the people get these effects. That's a very high percentage. So mild nausea is very common. It's rare not to have some nausea.
Okay.
But that's usually people handle it well. More severe nausea and even vomiting and sometimes significant constipation. I've had patients very distressed by constipation. Episodes of diarrhea. All these are known and they're not uncommon.
And why do they happen?
Because it's a gut hormone basically. So it's acting on the gut.
And everybody is responding differently.
Yes, differently. Imagine constipation and diarrhea, either can happen.
Yeah.
So they clearly have gut-related side effects. Now, that is a downside, of course. The day you have some molecules that don't have those effects, it'll be another huge jump. Nevertheless, most of these side effects can be managed by normal stuff.
Like?
Take an antiemetic, take a pantoprazole or something, for your acidity, take something, isabgol for constipation. Most of them can be managed like that.
And how long do these side effects last?
And the other important point is that they're mostly transient. So people who are able to hang in there for, few weeks, they usually do very well. Now, the problem is that these drugs are started in low doses and built up slowly. It's very important to start low and go slow. So because the drugs are started at a low dose,
and typically it's once a week.
Once a week injectable. So if you
self-inject or
self-inject. So every time you go up on the dose, again the side effects may flare up temporarily. But I've seen that by that time, patients are pretty well used to handling them. It's the first few weeks that they really require help. I think, and I was saying this, it's quite amazing how much people will tolerate for the sake of weight loss. Whereas the doctor is looking at the HbA1c and the body adipose tissue and the decline in blood pressure and lipids, etc. Patients will tolerate these side effects for the sake of weight loss. I find that actually amusing in a way, because they will complain about the most minor side effects of any anti-diabetic or BP medicine.
Yeah.
But this, no, we'll manage. Moment I say, no, I'm going to stop it. No, I've lost.
Is it because they see results? And with a lot of
Yes.
other things, you don't see the tangible results immediately.
It's a physical effect.